Good afternoon, everyone. Welcome to this special session. I'm Mariam Fadel, Associate Professor of Ophthalmology at Cairo University. And I would like to start by thanking the Egyptian Ophthalmological Society Board and the organizing committee for their interest and support in the integrated care in ophthalmology. Today, we aim to reflect a shift in mindset, a twist in how we perceive and approach this complex disease. Uveitis is not an isolated ocular condition. It is always and often related to a systemic problem. In this course, we aim to challenge the outdated silos and share insight for the multidisciplinary care. And we are pleased to be joined by two eminent professors. They are on their way, unfortunately they are late, in the field of rheumatology and chest. My gratitude goes to our distinguished panelists for sharing their experience and cases today. Unfortunately, Dr. Mohamed Al-Azim is يعني عنده حالة وفاة واعتذر، فاحنا النهارده بنشكر جدا دكتور سمير شوقي، دكتور علاء رضوان، دكتور دعاء، دكتور دينا بدار, and Dr. Noha Osama for sharing with us their cases today. I will start with describing how this multidisciplinary vision can meet reality. So what is MDT? Multidisciplinary is when combining different specialties to approach a certain problem, while cross-disciplinary when they meet to discuss this problem, and interdisciplinary where they actually meet under the same roof at the same time to take the history, examine the patient, and tailor the workup, and put a protocol of management for the cases together. So why do we call for this approach? Uveitis is not a standalone diagnosis. It is a clinical sign of a wide spectrum of systemic diseases. So imagine if you are in your clinic and you encounter an everyday case like this girl, 11 years old case, who came complaining and her parents with bilateral redness, photophobia, and diminution of vision of insidious onset, progressive course, and chronicity in duration. Her clinical picture revealed posterior synecdoche with clear cornea, posterior subcapsular cataract, complicated cataract, and severe activity in the anterior chamber. You would think I would give her topical treatment until I refer the case to my colleague in the rheumatology field, and I will wait for the workup to be established. But what if I tell you that the recent updates or the recent publications describe this referral process in patients with uveitis as a challenging in the health system? And this is because they found that the average duration between the first ocular symptom and uveitis consultation was 2 years. And the ophthalmology referral or subjective referral, one can put one line and the other can write a story, and likewise in the rheumatology referrals. So the main concerns by the experts in rheumatology was that the ophthalmology referrals had too sophisticated jargon, and the ophthalmologists said that there is always delay in appointments in rheumatology consultations, lack of detailed clinical information, lack of specific diagnosis, and lack of combined protocol of management. And therefore, this will eventually lead in delay in presentation even if the patient sought medical advice. And even if he sought medical advice, there will be delay in the index of suspicion, which may lead to delay in diagnosis and eventually results in delay in management and treatment. We are in 2025. This is the era of preventive medicine. And this delay must be avoided. And we can start with early detection with the multimodal imaging, the early diagnosis and early management with the MDT examination workup and targeted therapy. So how does it work? We have to start with building a common language through using keywords from the ophthalmologist to send to rheumatology in working together in these cases, such as the disease activity level, the laterality, the course of the disease, the systemic manifestation suggesting the underlying systemic illness, and the current inflammatory status. These keywords are different from the keywords used from the ophthalmologist to his colleague in the investigative unit, like the disease activity details and scoring system, the duration and the complication, the ocular complications such as hypotony and cataract, and the trials of periocular managements. So the keywords from rheumatology to ophthalmology are huge and numerous. We cannot list it today, but at the end, these keywords should be included in the ophthalmology and rheumatology referral. This is crucial for a better outcome of disease management. So by 2022, we thought to shift this mindset. And since the ocular inflammatory disease is related to lots of systemic problems, we have to have for this facility a moderator for this multidisciplinary team. And always remember, our ancient Egyptian ancestors are well known due to their meticulous documentation. So never forget, if it's not documented, it didn't happen. So that's why we have to build a conjoint interdisciplinary medical sheet with detailed history taking while we document the primary presentation, the subsequent follow-ups, and the tailored workup. And since these patients require long-term of treatment and follow-ups, this sheet will be very hectic on the physician, so we need and better to go for a digital documentation. Number 4, the setup and circulation, it has to be 2-in-1, which means we have to have an ophthalmology equipped office at the same place as the internal medicine office. And sometimes this place may accommodate more than 1-2 specialties according to the type of the disease. The primary visit is usually the longest visit. It may take up to 45 to 60 minutes per patient. This is because the history is the most important key in this visit. It makes you predict and visualize the possible diagnosis. And in this visit, we must grade accurately the level of activity in the anterior and posterior segments based on the some criteria and according to the anatomical location, clinical course, etiology, and histology. At the primary visit, you need to take your time and count the anterior chamber cells accurately and define the level of activity in the posterior segment because this is the baseline examination and it is very crucial to build on it the therapeutic response. You can also mount a camera to document and make a real documentation of your clinical pictures. Specific signs guided by the ophthalmologist will then be referred to the rheumatologist where he does again his meticulous history taking and systemic examination and trying to search for specific signs, and at that point we can start tailoring the work up together. And never forget to always exclude infectious mimickers. The second visit is usually after 1 or 2 weeks, and here if the workup concluded that it might be a case of non-infectious uveitis, you can start by the anti-inflammatory or the specific immunosuppressives. And you can start with tapering the topical steroids and putting a regimen or a protocol of treatment according to each case individually. As an ocular immunologist, I appreciate the meticulous protocol of immunotherapy prescribed by our rheumatology colleagues. And the third visit and follow-ups depends on the disease itself, where we monitor the disease progression, the therapeutic response, the level of activity, whether it's controlled, in remission, relapsing, and we can reevaluate. So the power of interdisciplinary approach is in the detailed history taking, the early index of suspicion, the tailoring of the workup. This leads to early diagnosis and monitoring the disease progression and therapeutic response. And since the eye is the window to lots of systemic diseases, and it is actually the only organ where you can see the vessels in vivo, the ophthalmologist is the maestro who guides the approach through specific eye signs. So, for example, the episcleritis and scleritis can lead us to collagen vascular diseases, the granulomatous KPs and the iris nodules, which can lead us to the TB, sarcoidosis, and masquerade syndromes. The signs of fibrinous hypopyon with the specific course of the disease, the alternating ping-pong pattern, this can lead us to the HLA-B27 associated uveitis, and the cold hypopyon with the systemic manifestations of Behçet's. The pancreatopathy is a sign of chronic anterior uveitis, and it may not be associated with any symptoms at all. We can usually see it with the GIA patients. Whenever we see vitritis or severe vitreous, don't forget to exclude infections. And the snowball vitritis and snowbanking are signs of specific diseases like MS, sarcoidosis, or TB.
انت الشنطه دي
احنا ثانية واحدة احنا في محاضرة اتلغت فالدكتور هنا بيتكلم بدل الدكتور we can extend the time. The multifocal chorditis and Sunset glow fundus with the specific dermatological signs like vitiligo and poliosis can lead us to the diagnosis of BKH, and here we can need a dermatologist on board. The retinal vasculitis is always a broad spectrum sign, and the fundus fluorescein angiography is the gold standard investigation for this disease progression. Always exclude infection, because the most common one in Egypt that we see nowadays is the presumed trematode granulomatous anterior uveitis, and the history is contact with late water. And in immunocompromised status, don't forget to check the acute retinal necrosis. There are other infectious causes that can be treated with a simple antimicrobial like the Toxoplasma chorioretinitis and the Bartonella neuroretinitis. The greatest mimickers such as TB uveitis, and lots of times it is without any pulmonary signs, and the syphilitic uveitis, which always comes late in the presentation because it mimics the Behçet's due to oral ulcers and genital ulcers, and some patients may receive immunosuppression in the early course of the disease, which lead to severe immunocompromised status like this case. And in these cases, don't forget to look for the skin, and the dermatologist has a great role here because the palm biopsy is sometimes conclusive. The masquerades are on our list, and choroidal metastasis may be a sign of bronchogenic carcinoma. So to conclude, imagine a basketball team that has not mastered the concept of passing the ball. Or imagine a conductor or a symphony who cannot coordinate multiple physicians. So in this field, the uveitis dermatology team is aiming for a better quality of life. And the Focus Initiative group made this consensus because they thought that this improves standard of care. In 2021, the uveitis multidisciplinary service started at Cairo University under the supervision and leadership of our professor, Dr. Mahmoud Suleiman. And until today, we saw together and managed 2,500 cases. Until today. We also were partners in scientific meetings, and we shared different podium in the alternating specialities, which enriched our knowledge towards this disease and field. In 2024, a group of rheumatologists and ophthalmologists all over Egypt, we gathered to make the Egyptian uveitis study group, and this group has more than 50 members. And last week, we published our first teamwork publication, the Egyptian Consensus Guidelines for Treatment of Adults with Non-Infectious Uveitis. And because I think we need to go further, I would ask Dr. Nihal Ghobashi, Associate Professor of Rheumatology at Cairo University, who was a leader in this work. And I would like to ask you about your insights and about your experience in managing the uveitis cases before and after the MDT approach. Thank you.